Bismillahirrahmanirrahim. The tissue repair is a stepwise process right from the formation of a thrombus to the scar formation, but there are some abnormalities or aberration in this tissue repair. These are discussed in this video. Following are the references for the video. So the tissue repair can go wrong in three major ways. There is deficient scar formation, and the cause for this is inadequate formation of granulation tissue or collagen deposition, and this results in bone dehiscence or wound reopening and ulceration, especially if the vascularization is poor. It is commonly seen in nutritional deficiencies such as vitamin C deficiency, diabetes, and infection. Then there are excessive scar formation occurs in uh, hypertrophic scar or keloid. The hypertrophic scar is a raised scar but stay within the boundary of the wound and often improves over time, while keloid it grows beyond the boundaries of the original wound, and it is commonly genetically predisposed. And there is excessive type 3 collagen deposition. There is another aberration, that is exuberant granulation tissue formation, and that is also termed as proud flesh. There is excessive granulation tissue formation that blocks the reepithelialization process. Then finally there is a development of contracture. There is exaggerated wound contraction that results in functional disability due to tissue distortion, and this is common after severe burns frequently affect the skin over joint and lead to limited mobility. So deficient scar formation occurs whenever there is inadequate formation of granulation tissue or inability to form a suitable extracellular matrix component. So tissue repair may be compromised due to issue in collagen deposition, cellular proliferation, or wound contraction. The wound dehiscence is the reopening of the wound after initial closure, and this is most common after abdominal surgery and may become life threatening due to organ exposure or infection. The main risk factors for this wound dehiscence are increased abdominal pressure, and as happens in vomiting, coughing, obesity, and bowel obstruction, and metabolic deficiencies, hypoproteinemia, and cachexia in metastatic cancer. Incisional hernias are weak surgical scars, and that will result in defect in abdominal wall. The loop of bowel may herniate through the weakened area, and it is caused by insufficient deposition of the extracellular matrix or poor cross-linking of the collagen. Another complication in the wound repair is the ulceration, and these wounds may ulcerate due to poor perfusion, ischemia, neuropathy, or pressure. The venous stasis ulcer are due to failure of venous valve that will result in edema, and it will lead to the formation of pericapillary fibrin cup formation, and these fibrin cups will lead to stasis. These ulcers are most commonly found in Western population, and the common site is medial lower leg. The arterial ulcers are formed due to atherosclerosis or peripheral artery disease. They are found uh, on the lateral lower leg or foot. The diabetic foot ulcers are a combination of ischemia, both the arterial ischemia as well as the capillary insufficiency, neuropathy, that is the loss of sensation, and impaired growth factor signaling. So there is a risk of deep infection that will lead to osteomyelitis, and this will require limb amputation if left untreated. Then the third one is the decubitus ulcer. These decubitus ulcers are the ulcers that are present on the bony prominences in the immobilized patient. Local infarction occur and it develops within 2 to 3 hours of sustained pressure, can become deep, wide, and may severely infected. So that will lead to the development of ulcer. So this set of pictures is showing the chronic ulcer healing. It is showing there is persistent inflammation, incomplete reepithelialization, ongoing fibroblast activity, early fibrosis, underlying poor vascularity, and these sort of ulcers are characteristic of diabetic ulcers, pressure ulcers or arterial ulcers, where tissue perfusion, regeneration capacity, and immune functions are compromised. Over here, this is a clinical photograph showing a chronic ulcer located on the grade 2. The ulcer is round with an elevated margin and central depression. The surrounding skin is shiny and atrophic, suggesting ischemic or neuropathic ulcers, likely related to diabetic foot ulcer, peripheral arterial disease, or pressure ulcer. Over here, this is the cross section of H&E stained tissue with deep ulcer crater. Loss of epidermis, there is a loss of epidermis, and the underlying dermis is visible clearly. The ulcer base is showing dense inflammatory filtrate, granulation tissue, early fibrosis, and here on this high power view of H&E stain that is highlighting the ulcer base under higher magnification, there is dense infiltration of the chronic inflammatory cells, mostly composed of lymphocytes, plasma cells, and macrophages. There are numerous dilated blood vessels, and this is the early granulation tissue formation. There is also disorganized extracellular matrix that is present over here, and in this area that is adjacent to the skin, there is partial reepithelialization of the ulcer, that is regeneration of the stratified squamous epithelium. There is active fibroblast proliferation in the dermis. The early collagen formation is seen over here, that is forming immature scar tissue. The excessive extracellular matrix deposition, mainly collagen, during wound healing will result in keloid formation or development of hypertrophic scar. Both of these conditions, the keloid and hypertrophic scar, represent disruption in normal wound maturation, but keloids are more aggressive and genetically influenced. The hypertrophic scar stays within the wound boundaries, often caused by mechanical stress on the healing wound, and can improve or flatten with time. More common as people age, and it appear reddened, raised, and itchy due to increased blood vessels or hypervascularity, and mast cell activation in that area. The fibroblasts produce excessive collagen that remains actively cross-linked and represent maturation arrest of normal scar remodeling and not associated with heredity or scar or any race. While keloid, it grows beyond the wound margin, appear as firm, shiny, nodular mass, and it occur more commonly in adolescents and young adults and common in upper trunk, neck, earlobe, and head. The scalp is spared, suggesting it is common in dark skinned individuals that is suggesting a genetic predisposition to this keloid. So it is difficult to remove surgically. They may recur or enlarge after excision, and they are also resistant to steroid, unlike hypertrophic scar. However, uh, they show excessive fibroblast activity and persistent collagen production. The histology for both type is almost same. There is thickened, disorganized collagen bundle formation, increased fibroblast, and more blood vessels than mature scar. And there is also high fibronectin expression. This image is depicting a patient's earlobe, and there is a large, dark, firm nodular lesion in the earlobe, and this is protruding from the site of the previous trauma or piercing. The keloid extends beyond the boundaries of the original injury, one of the hallmark feature of the keloid. The lesion has a smooth, shiny surface and irregular lobulated contour. Its color appears darker than the surrounding skin. Often, this is hyperpigmented, and it is common in individuals with darker skin tones. This site, the earlobe, is one of the most frequent site of the keloid formation following the ear piercing. So here the lesion is a raised, firm, shiny mass with irregular borders, and there is a lobulated surface. The keloid extends well beyond the original wound margin. That is the hallmark of the keloid. If its color ranges from pinkish to the purplish dark, reflecting the hypervascularity and chronic collagen deposition. The skin overlying this lesion is stretched, but it is smooth. The keloid, they behave almost like a benign tumor of fibroblast, and this activity is driven by abnormal healing response. They are notorious for recurrence after excision and are more common in individuals with dark skin phenotypes. The photomicrograph over here, this is a section, HNE stained section from a keloid, and here the epidermis is intact with normal stratification, and there is normal rete ridges. The dermis or the keloid tissue shows abundant deposition of dense and broad specific these collagen bundles. These are pink stained, and the collagen bundles are thick, glassy, or hyalinized and arranged in haphazard, disorganized pattern, characteristic of keloid, unlike the hypertrophic scar. The collagen fiber here show random orientation rather than the parallel alignment. There are relatively few fibroblasts present in this section, and the other features that can be seen are scattered mast cells that contribute to itching, but these are not directly visible on H&E staining. Capillaries and inflammatory infiltrate are minimal or absent, reflecting the chronic non-inflammatory nature of the lesion. The characteristic histologic appearance of keloid are collagen. Type 1 is more than type 3. The collagen arrangement is thick, disorganized, and haphazard. The borders of the keloid extend beyond the original wound margin. The fibroblasts are fair but hyperreactive. The vascularity is poor or diminished, and the clinical behavior is tendency to recur, and these lesions are progressive. This is another histologic section of the keloid, just to reinforce the concept of the keloid. Here again you can see that this epidermis is intact. There are normal ridges, and this is normally stratified. Uh, this is well preserved surface epithelium. Down there in the dermis, the most striking feature is this presence of dense, broad, eosinophilic, pink staining collagen bundle. These collagen fibers are thick and glassy, having hyalinized appearance, and they are arranged or oriented randomly and haphazardly rather than aligned parallel to the skin surface. The bundles appear to form whorled or swirling pattern, which is typical of keloid. There are some scattered cytoplasm, but they are fewer than active wound healing phase. Vascularity is also minimal, and inflammatory cells are sparse. This table is showing the salient features of keloid versus scar. The growth in hypertrophic scar is limited to the wound margin, while it extends beyond wound edges in keloid. The collagen bundles are parallel, thick, but organized in hypertrophic scar, but in keloid they are disorganized, but still they are thick. The vascularity is present in early stages of hypertrophic scar, but it is reduced in mature keloids. The common location of hypertrophic scar are anywhere more common on flexor surfaces, while the keloid is more prominent, more common in neck, shoulder, earlobe, or chest area. The recurrence rate of hypertrophic scar once removed is less frequent, while the keloid have got a high recurrence rate after excision. So the normal healing can be compared to a construction site where damaged bricks are neatly replaced, keeping the structure identical to the before or the earlier structure. While keloid formation is it depicts an overzealous construction crew that is piling up excessive bricks far beyond the damaged area, leading to a large, bulky structure that distorts the surrounding, just like collagen of the keloid that extend beyond the original wound. Another abnormality in the wound healing is abnormal wound contraction. In typical wound healing, fibroblast and myofibroblast help to reduce the wound size. These cells form connection, that is the cell to cell contact, and after the cell to cell contact, they exert sustained contractile forces to pull the wound edges together. If this contraction is exaggerated or unregulated, it leads to contracture. So contracture is an abnormal excessive tightening of the wound area causing severe deformity of the wound, distortion of the surrounding tissue, and functional impairment. The analogy concept that can be used to understand this mechanism is the over-tightened drawstring bag. In normal wound healing, the fibroblast and myofibroblast they gently pull the edges together like drawing the string of a cloth bag neatly. In contracture, the strings are pulled excessively, causing the bag to pucker, wrinkle, and distort. The bag shape is deformed just as the wound contract abnormally, causing tissue distortion and limited movement. The surrounding area represents the locations prone to contracture that are palm, sole, thorax, joints, and alimentary tract, as well as GIT. And after burn, there is some development of contracture also. Clinically, after serious burn, contracture can significantly limit joint movement. In the alimentary tract, there can be development of strictures, and then these structures can obstruct food or intestinal flow. There are some special conditions that involve contracture without any injury. These diseases are characterized by fibrosis of the superficial fascia without prior injury. These are Dupuytren's contracture that occurs in the palm fascia, the Lederhosen disease that occurs in plantar fascia, and Peyronie disease that occurs in penile fascia. The exact trigger for these conditions is unclear, but the basic fibrotic mechanism resembles the abnormal wound healing. So the contracture is an over-exaggeration of the normal healing process, leading to deformity, fibrosis, and functional problem, often in a highly mobile or tension-bearing region of the body. Thank you for watching this video. If you have any query, please write in the comment box.